Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome, everyone. My name is Renee Garrett, and I'm your Speech Therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Maurice Goodwin is a salaried employee at Houston Methodist Hospital and is an adjunct faculty at Lamar University in the Vocology program. He receives compensation from Speech Therapy PD for this presentation. Maurice is the owner of Goodwin Voice and Speech, PLLC, and the co-founder and owner of Voice Pro Ed, and has no relevant non-financial disclosures. Renee Garrett is a paid employee of a private consulting firm in the Commonwealth of Virginia. As the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on Speech Therapy PD, I do receive financial reimbursement. And I also am my non-financial disclosure is I'm the secretary for the Communication Disorders Foundation of Virginia. So without further ado, we welcome our guest, Maurice Goodwin, MS, CCC-SLP, who is a licensed and practicing speech-language pathologist, voice teacher, and active performer living in Houston, Texas. Professionally, he specializes in the evaluation and treatment of the singing voice and voice disorders at the Texas Voice Center and is adjunct faculty at Lamar University and the Graduate Vocology Certificate Program. Following his undergraduate studies in music performance at Shenandoah University, he completed his graduate work in speech-language pathology at the University of Pittsburgh. During his time at the University of Pittsburgh Voice Center, he completed his graduate thesis on the challenges and changes that occur in the voices of elderly adults. His background as a performer and speech pathologist led him to complete a fellowship at the University of Wisconsin Voice and Swallow Clinic in the treatment of singers, actors, teachers, and other occupational users with voice problems. He's a regular lecturer and presenter at national and international conferences focused on the health and education of professional voice users. He's passionate about vocal health education and the intersections of identity and voice. Maurice, thank you so much for being here. So nice to finally meet you.
Thank you for having me. It's great to be here as well.
Now I read the other bio instead of the one that you submitted because I found some really cool, interesting things about that. So I didn't know you went to Shenandoah, which is, of course, in my state.
I did. I went to Shenandoah University, their conservatory program for undergrad. I love Virginia. If there's another state that I could live in, it would probably be Virginia.
Yay! Yeah. So incidentally, we took our son there when he was a senior in high school because he wanted to major in music performance. And we went up to Shenandoah far before it had a couple of things. One, restaurants. And two, speech language pathology program, which they started this fall. So it's pretty cool. We're getting some feedback from people that they're having a hard time hearing you.
Let me adjust that a little bit.
There you go. That's better already. Yeah.
Okay.
Yeah. So thank you for the Virginia shout out. But interestingly enough, too, I wanted to ask about your background, if that's okay with you as a performer, because I don't really know a lot about that as well.
Perfect. Yeah. I'm also like chronically, as a speech pathologist, a bit of a quiet talker. So I can just speak a little bit louder and clearer.
Okay, there you go. Because I'm getting mixed reviews that it's all good, and then they're having trouble hearing you. So Maurice is practicing good vocal hygiene. But yeah, tell us a little bit about your background as a performer.
So I went to undergrad for music performance. I had grown up in a musical family. So that influenced kind of the decisions that I made after school. And I finished a degree in vocal performance. It was in that degree program that I realized I did not desire to be a singer full time. And that's when I started to kind of explore what else could I do with the background that I had, with the knowledge that I had gained during undergraduate studies with my own voice and with other people's voices. And that's when I found speech pathology.
Very cool. Yeah, my son actually wound up not being a music major either. He wound up majoring in psychology,
Oh, yeah.
and he's an accountant.
Oh,
Very random. But I think, that's a good segue into a lot of us who maybe don't have a performance background, or whether that's singing, acting, musical theater type stuff, whatever the case may be. We don't, a lot of us as clinicians don't have that background. And so we kind of feel like it's a little bit harder to maybe understand the voice. And I have my own thoughts on that, but as the voice professional, what do you think about that? Is that accurate?
I think I hear that a lot from folks as well when I teach or when I go places or just people interacting with me, particularly online. They'll say, I'm not a singer, I'm not a performer, I haven't had voice lessons. How do I do voice work well? I think at a base level, many of us are functioning just like our clients do if they're coming in with voice problems. So we've given lectures, we've given presentations. Many of us still use voice as our primary form of communication. And so while we may not have the problems our clients do on a regular basis, we are definitely using our voice. And every time we yell across a room, every time we try and say something a little softer because we're trying to tell maybe a friend a secret, every time we shout across a field, we are doing things with our voice. And I think the difference maybe between somebody who studied that is how to be intentional with that. But I think the speech pathologist's experience with their own voice and their own body, as well as the knowledge that we gain in graduate programs and voice disorders, is more than enough to be a confident and competent clinician.
Yeah, it's interesting that you say that, because a lot of people who specialize in voice don't necessarily agree with that. And I will say this for myself, so a lot of people who listen will know kind of what my background is, but I started out in inpatient rehab, and then we also had an LTAC floor, long-term acute care floor, and then I went to acute care before I went to outpatient. And so this term of generalist has been kind of bouncing around for the past few years, and it's got a lot of negative connotation with it, that you didn't specialize in anything, so how could you be good at treating all the things?
Right.
But if you've worked in any of those environments, you don't get to pick and choose who your patients are. They just sort of show up, and you got to figure it out and become competent at a lot of things that maybe wasn't in your plan. What are your thoughts on that? Because, when you're teaching also in a graduate level program, you're specialized in this area, but the real world as well.
Sure. I think even that comment maybe inspires something in me too. We sometimes ascribe to people who studied voice, either singers or actors, as if they understand how it works. But that would be like saying because you've eaten a meal, you understand how swallowing works, or because you've thought a thought, you understand cognition. But that's not true. We went to school to understand those things. And so they are skills, and it's knowledge that can be learned. It's not intrinsic to understand how vocal cords work. We learn it, right? And so by proof of the fact that I know how to do it and I feel confident doing it, I believe anybody can, if it's what they want. And I think that's true in voice, but especially in any other area. I think that I, am not necessarily the most skilled clinician. I practice in a super niche part of our field. I do not envy folks who work in a general outpatient setting. I do not know how you do it. It does not make sense to me that you would hold that much knowledge in your brain. But I have colleagues of mine in the same hospital system that I work in who are extremely competent colleagues who do work across like a spectrum of disorders that come into the clinic. So I know it's possible and I see it being done on a regular basis.
Yeah, and honestly, if it's voice that's unrelated to stuff with reflux, sort of the standard thing where we start in outpatient, seeing those cases that are more, the referrals from GI or ENT that maybe had a pathology, or maybe they had a stroke with some unilateral vocal cord paralysis. I've been doing that for a long time, but if it comes to singing voice, I'm going to say, probably not me. I'm going to refer you to the person locally who I know is that person. We have the benefit here of having a local medical school who has a whole vocal swallowing voice entity of physicians, great otolaryngologists who specialize in that. And they have gotten a couple of SLPs now. So that would be where I'd send them. But let me back up for a second. Can you talk to us about your experience working at doing work with the University of Wisconsin? Because that's one of my go-tos for years.
Sure. I felt very, very lucky to do my training there. It's a bit of a bastion in terms of research and being productive in our field, and they've produced a lot of really wonderful clinicians and researchers. So I had only spent a year there for my clinical fellowship, but that pretty profoundly impacted the next few years of my career and probably even now. And it was just a great place to learn. They are heavy on learning and making sure that you learn as much as possible. So it was also just like a great clinical environment that took the time to teach me. It was also extremely intense. So I felt like after my clinical fellowship, I probably could do anything that my job would require of me. I've since life has proven that a bit wrong, and I've had to learn over and over and over again, but it was good. It was like a really great foundation for what is now, I'm 7-8 years into my career.
So what would you say are some ways maybe after that, other than your performance background and your experience, just from your family and your collegiate experience, what would you say would be ways that clinicians can gain more competency if they're going to specialize maybe in treating voice disorders, not just having, singing voice is one of the things that they do, but just as voice disorders as a whole?
One of the things that
that's a wide variety.
Yeah, is that folks get comfortable playing with their own voice. So I know often that happens within the context of something like a voice lesson or joining a choir, but even just playing around with your own voice and being conscious of the choices that you're making can be really helpful within the therapy space. This was actually something that Ruchi had mentioned when you had interviewed them, right? It's this spirit of play when it comes to voice. And to me, the parallels when we think about like speech and language in children, or when we try and get to like generalization in a lot of other areas, it's all about like, how do I make this as functional as possible? How do I understand it to a point that someone can then apply it? And voice is pretty the same. Yeah, a lot of play, a lot of explore, a lot of experimentation with your own instrument really helps give you the tools to guide someone else through that process.
Yeah, and it's funny because when I started an outpatient, I had a couple of voice apps that I was using with patients just to give them some biofeedback, and I used it on my family just so they could see their own biofeedback. And it was interesting because I think sometimes, if you have a significant other or family member that you can do that with, it's helpful because it's not just you, but they're kind of sharing in that experience of what you're bringing to your patients. And I don't know, sometimes I feel like they're very good.
Yeah. The other thing that I think is helpful, outside of just like understanding yourself is understanding that kind of, again, I've used this word before, but foundational level, vocal folds are muscles. And the larynx is a system of muscles and nerves. Those things work together to create the sound that we hear. And so if I understand how that works, I can then do a lot with it. I sometimes I struggle communicating this because to me, voice feels very obvious. They're muscles. And if I understand how muscles work, then I can take advantage of those muscles to produce, the thing that I need to, or the thing that the client needs to. And sometimes with voice, I think we get outside of that. We think so much about quality and, well, I can't make that quality, or what about this singing voice? But even as a voice therapist, I actually don't think about quality as much as I think about function, right? If I can help someone function better, they very likely will have a better quality. And so all I have to do is think about function. All I have to do is think about how muscles and tissue work to get the outcome that we want. And in that approach, it tends to be a bit more physical. I think about muscles a lot, and that is extremely helpful.
Yeah. And I think when you're thinking about function morphing into quality, what are some basics that you would recommend for, even for vocal hygiene or things like that, where we think we know, because it's always like hydrate, drink water.
The good question. I off the top of my head, one that I will see a lot is that if your client has any sort of dysphonia, we often ask patients to do less. But that isn't always necessary or the best response to dysphonia. Of course, if there is a tissue issue, as I like to call them, like nodules, polyps, or something going on, on the epithelium, then we'd maybe be aware or cautious as we're approaching voicing. But there are many a voice problem or a voice disorder that actually involve more work, that involve turning the voice on more frequently. For instance, I see a lot of patients that come in with a vocal fold paresis or vocal fold paralysis who were told that they need to rest their voice. But there's nothing in the literature or data that says that resting your voice improves the status of a vocal fold paresis or paralysis. We have to do the opposite. We got to turn the system on and figure out ways to function within the context of weakness. And even within something like nodules or polyps or a tissue issue, again, the data over and over says that learning how to use the voice in a way that's productive, in a way that feels good, in a way that reduces impact stress, improves the status of the larynx, not doing nothing. And so I think changing our mindset from like doing less is more, to me, I approach my sessions sometimes with doing more is more. I'm empowering the person to use their voice in the way that they want to, and helping them find strategies for communication, for doing their job, for doing the thing that they want to do with their voice.
Yeah. And I think, again, that standard set of don't overuse your voice, don't talk excessively. I've even seen don't whisper as strategies from other clinicians. And I'm like, that one always baffles me, because don't whisper. I don't understand how that is harmful or helpful.
Is it the client will then come to me and say, well, here are all the things my last clinician told me not to do. But they don't really start off with what they told them to do. Right. And so we as therapists end up doing a lot of stop it therapy, which it does not work with human brains, right? I want to give someone this positive experience where, again, they feel empowered to use their voice in the way that they want to. So I want them to leave thinking about the things they can do to help their voice, not the things they need to avoid to make it worse. It's just kind of a change in approach and perspective that I found people respond to very well.
Yeah. And I think it's that one size fits all is not one size fits all, right?
No.
It's thinking about, again, the function. So are you talking about someone who is a performing singer, or is it someone who's a teacher or a pastor where they utilize their voice constantly all day long? Or I've had other SLPs who were clinicians who were at the end of their career retiring, who now have voice problems because they've used their voice in a way that maybe wasn't the best way for them.
Yeah.
Actually got a couple of questions. So Amy said, are there any voice apps that you recommend? Amy, do you mean for like a biofeedback, or do you mean something more specific? If you want to type your answer.
There is an app that I use pretty regularly, and I'll actually give two apps. One app that I use is called, I don't know if I'm allowed to say this on the podcast. I'm assuming I am. We are not sponsored by them. It's called Tunable, Tunable. And it's just a music practice tool. But what it has is like a pitch. So it's a pitch thing. You can press like the pitch. It's not a piano keyboard. It will say like C, D, E, F, G, which can be helpful, especially if you're doing something like vocal function exercises. But also if a client is like holding out a pitch or talking, it will actually give you the pitch range that they're speaking in. It is a paid app. It's a couple dollars. Maybe they're having a sale during this season. And then the other one that I use all the time with voice clients is my voice memos app, or just an app that will record the audio of our sessions. Voice is about voice. And often what we'll do is we'll like practice voice and then give our clients a worksheet. But what I do is practice voice and give them a recording of them practicing voice so that they can start to listen both to my production and their production and become significantly more aware of what they're doing with their voice. So I record a lot of my sessions, and that's something that I took from my own work as a singer and a performer. You record yourself so you can listen back and adjust, and I implement that with every session with a client. Every session I'm making recordings of their voice and sending it back to them to think about and listen to.
Yeah, that brings up something. So I used Voice Tools, which is that one's a free app, and that's the one I used on my family, and they thought it was hilarious because it does give you pitch frequency, but it analyzes your voice like a spectrogram.
Yeah.
Right? So you can see that immediately. And I don't know if you did this full time as a voice vocalogist, if it would be helpful. I just thought it was fun to kind of play around with. And some patients really love that biofeedback, especially people who are not performers, like some of our elderly or geriatric clients really like to see where their voice felt because they were experiencing a lot of symptoms from their reflux disease. And so it was helpful for them to see it. They got more out of the session because they didn't just, a lot of people will come in and say, I'm hoarse today, but I wasn't hoarse yesterday. But for them to see it over and over, they kind of get that biofeedback that's really helpful for them and that visual. But what I was going to say was that my undergraduate students, I teach a technical writing clinical observation class, and we do a lot of clinical observations together. And we did one on someone that was a transgender voice client. And the clinician was using a lot of that biofeedback, that auditory, that recording of the clinician's voice and the client's voice. So it's kind of a perfect segue because we just watched that video like 2 weeks ago. Yeah. And the students really had a lot of really thoughtful questions and a lot of feedback about that because it was unfamiliar to them.
Yeah.
They hadn't seen anything like that before. So it was very interesting for them to experience that. And for me as a seasoned clinician to hear that from them. So Alexandra asked, the free app is called Voice Tools. And again, I'm not a paid spokesperson for that. I'm not advocating any evidence-based practice or anything like that. I found it fun. I found that my particular clients that I was seeing at the time, they just really liked seeing what they could see. The visual feedback for them was very helpful. It measured pitch, frequency, and I'm trying to think of the other things, but it was interesting to see that. And it's a great way for technology to be included because we are sort of moving into this world of technology for, anything from virtual reality to AI, sort of the wave of the future, but also right now.
Yeah,
So,
for sure.
Yeah. And I think for me as a clinician, if we had vocal anatomy taught in that way instead of some old school anatomical drawings. And we actually had someone in my voice class who had a very old school coloring book.
Yeah. Oh,
that they colored in the anatomy and shared it with the class, which was really helpful because visual feedback is always good. So when you're thinking about singers versus people who speak like us as clinicians, or people who are teachers in other facets, or someone like a pastor who they're just using their voice a lot, what are some vocal basics as far as anatomy or quality for those folks that may be something we need to keep in mind?
yeah. I think when you're working with singers or a professional voice user, again, some of the I think there's a common or shared belief that you have to be to help someone, right? That I have to be a professional singer to help a singer, or I have to, but no one else has that standard, right? The singers aren't going to laryngologists or otolaryngologists and expecting them to be performers. They're coming to them for the knowledge that they have about how the voice works. This would be similar to a professional athlete who works with a PT. They're not expecting that PT to have been in the NFL to help them recover to their baseline. What's funny about this question is a lot of my clients have no idea that I have a music degree. All of my clients have no idea that I have this long history of performance, because when I am working with a singer or someone who's using their voice, it's actually not about me. It's about them. And
Yeah.
in that room, I allow the client to be the expert in their voice. And all I am is a speech pathologist with a ton of information about how a voice can work. And so I let them tell me how their voice works, what's not working for them. And then I just apply all this knowledge that I've collected over these years to see if we can help them out. And that's really, really deeply, truly it. It doesn't have to be more complex than that. There are some clients that, depending on their like performance situation, I can play the piano. So I have a piano in my clinic, and if I need to, I will hop behind a piano. But every session of mine with a singer or performer does not look like a voice lesson, and it shouldn't. That's not my job. So again, when it comes to working with folks who do something that you don't do, well, that's every day. We work with people that have different lives than us. And I let them be the expert in the thing they need to do, and me be the expert in the function of it.
I want you to come back and teach me voice from my grad program.
Yeah, I mean, I think if we let that be kind of the root of a lot of our voice education, and then really voice is about doing, it's an actionable thing. It's not just about understanding. And, I think our field in general is definitely moving into potentially a new education model where we're considering what is the clinical application of a lot of this stuff, and how can we train clinicians. And I think that voice education and the way that we teach voice is due for a bit of an overhaul.
Yeah. Well, this could be a bigger conversation about a lot of things.
I didn't say this, but I do sit on the CAA board. I forgot to put that in my disclosure. So for me, thinking about graduate education and accreditation is something that occupies a bit of my brain these days.
Yeah, I hear you. We'll talk about that when I see you. So Patty says, besides staying well hydrated, what else do you suggest for good vocal hygiene, as in posture, breath control, etc.?
Yeah, this is a more nuanced answer. I think, of course, hydration can be really important. Topics like breath support or even reflux, voice rest or voice conservation, those can all be extremely helpful things. And I think it's more like, how are they applied? Not everyone with a voice problem has a hydration issue, and not everyone with a voice problem has a voice problem because they use their voice too much. And so sometimes I think we apply use-related hygiene practices to problems that aren't related to use. And again, I'm going to use the paresis paralysis. So if someone has a vocal fold paralysis after an ACDF procedure, they did not get that vocal fold paralysis because they were using their voice too much. And so the same hygiene practices that you would apply to a teacher may not apply to someone in that situation. And so really allowing yourself as a clinician to be flexible with your hygiene recommendations means anything can actually be a reasonable recommendation. It just kind of depends on the person's circumstance. One that I will do, vocal hygiene practice, I guess, again, for the right person, I would recommend like steaming or nebulizing just to kind of add to the hydration. So drinking water is systemic. Steaming or nebulization can be surface. And so that can be a helpful tool. And then I use a lot of like self-laryngeal massage as a hygiene tool, which sounds odd for hygiene, but I see it no different as if you were an athlete or someone in physical therapy who needs to stretch before you get to work, or stretch before you quote unquote, work out. And so I encourage a lot of my clients to do that, also to kind of increase their own kinesthetic awareness of their voice.
Yeah, and old school one I used to hear from singers, and not that I was treating singers, this was just like people that I knew who were singers, eating potato chips, which I was like,
yeah,
so random, but they talked about getting the oil, but then the salt is drying. So I never understood that analogy
what's
at
fun
all.
is that singers will I think humans in general have stories of how their body and their life works. We all have a story, right? And a lot of us sometimes have similarities, and there are some folks with differences in that story. I actually don't see my position as like negating any of that. So if someone tells me that they eat 3 Oreos and have a shot of whiskey before they perform and they never performed better, have fun. Sure. It's not my job to tell you what does or doesn't work for you. Here is maybe what else you can do to help out with this specific thing that you have going on,
3 Oreos. I'm like,
I don't know.
I don't care about the whiskey part, but the Oreos, I'm totally like, I'm into that. Like Friday before I present, maybe I should get me 3 Oreos.
I'll meet you at the convention center. Yeah.
So Lisa says, how long does therapy last in general, or should it be a certain number of visits?
That's a good question as well. So this is I say a couple things to my clients actually starting off therapy. In our voice center, we are very, very busy. And so we do not have the ability to see clients for a long time just because of the way our schedules work. So clients will initially schedule about 3 or 4 sessions with me, and then I will reassess. And so I'll say to the client on the first session, what we're going to do is try voice therapy. And if you are not successful with that therapy, that does not mean you are a bad client or I am a bad therapist. It might just mean we need to explore something else. But if at the end of those 3 or 4 sessions, you feel like you're making improvement, I do not like doing therapy that is not beneficial or impactful. I do not like doing therapy where we don't see change. And I don't think that change needs to be immediate, but if I cannot observe or see measurable change in the first few sessions, then I don't tend to continue it.
Makes sense.
Yeah.
And Virginia, I apologize. I just saw your comment. So Virginia said, in general, no specific disorder going on, isn't whispering hard on the vocal folds. This was very stressed in my graduate program.
I don't know that there's any data to suggest that whispering is any harder. I guess it depends on how you whisper, but I don't think anybody is whispering for so long that they create damage. But that would just be my recommendation. So if a client, really at this point, if a client comes in and says that they were told they shouldn't whisper, I just tell them that they can do what they think is best for their voice. And maybe in our relationship together, they find out that whispering isn't all that bad. I know I really, really try not to do the like, don't do this with your voice, because that's not my place to tell someone to or not to do. I can help them explore their own voice, and then they make the decisions that make the most sense for them.
And then we this is the most questions I've had in quite some time. So this is exciting. So Amy said, any thoughts on the treatment of presbyphonia?
Yeah, presbyphonia. That was one of those things that I was like, turn the system on. Let's get these muscles working. My presbyphonia sessions look like I'm shouting at people for 45 to 50 minutes, but it's not just intensity that we have to think about. So if we think about, again, how the larynx works, it moves a lot. And intensity is one variable that we can control. So sometimes when we think presbyphonia, we think atrophy. Let's get those vocal cords together, right? You think something like vocal function exercises or forte, and that is intensity-based training. But another thing that I add is frequency-based training. So we are doing exercises all the way up and down the range. And again, you do not have to be a singer to go, ooh, or hold out high pitches, and teach your clients how to sustain those things. Again, The larynx moves in a lot of different ways. We want to get all those ways engaged for presbyphonia.
Yeah. And, thinking about presbyphonia, we tend to see that more in our geriatric clients, but are there other things that could maybe contribute to that as a diagnosis?
Sure. I mean, when we think about presbyphonia as a diagnosis in, I guess, with aging, of course, we have changes to the respiratory system that begin like in our 30s and 40s. And then we just have natural changes in articulation and resonance. I mean, the tissue changes, the reaction time, co-articulation, all of that shifts and changes as we get older. And so it's important to remember as a therapist that, our perception of an aging voice is also more than just the quality of voicing. There's a whole lot of other things going on. And so having reasonable expectations, right? If you're 75, you're probably going to sound like you're 75, and that's okay to sound like you're 75. We don't have to be ageist when we talk about voice. We don't have to say that it's bad to sound your age. And I can hold space for the fact that I think folks can have a strong, clear voice for their entire life.
Yeah. Yeah. And I know for me right now, I'm kind of scared about speaking this week because we've had this drastic weather change where a week ago we were in the 60s and 70s on the coast of Virginia. And right now it's like 31 degrees and it's kind of killing my soul. But also I've been kind of hoarse and like scratchy the last couple of days. And now the thought of being on a plane for almost 7 hours.
And then the sleep and the time change. Yeah.
What's sleep? What's that? Yeah. So I think, there's a lot of things that we have to think about, again, for our own voice, but it gives us this kind of background challenge of looking at, you made a great point earlier about looking at what our patients' functions, needs, how they use their voice, what they need to be doing, and how they can conserve it. But conservation isn't for everybody. And I think we see that a lot, that's sort of the blanketed perception for voice disorders across the board without looking at the specific diagnosis and without looking at what the specific patient needs. So I think that was a really, really great point that you made.
But I think sometimes too, small mini rant, but I think it's helpful to consider in our work with clients is that also when we go to clients and we say, well, stop talking so much, a lot of these people use their voice for work. And so even if you do have nodules, or even if you do have a vocal fold polyp, or you're recovering from a procedure, asking someone not to use their voice, the thing that like pays their bills and feeds their children and funds their Christmas, is not reasonable. And then, we'll say, well, of course, use your voice to teach in the classroom, but then don't talk. But they have a 4-year-old kid at home, and they have a partner that they love talking to, and they have parents maybe that need extra help. And so they're on the phone with other caregivers. Like, these are humans. And so again, rather than focusing on what they shouldn't do, how can we help them communicate? How can we help them do the thing that they desire to do with their voice? It's really helpful to consider it that way.
And we're getting a ton of questions here. So this is great. So Val said, do you have recommendations for helping clients with breath support?
Yes. Yes. Yeah. I fall under the umbrella of speech pathologist. If you haven't heard this before, I do not think there is a correct way to breathe. Do I think that there are patterns in breathing that contribute to tension? Sure. And I will demonstrate that very easily. So if I were to take a high or clavicular breath, you can see that my chest elevated. Well, if you're listening to the podcast, my chest elevated and the muscles of my neck and larynx became tight on inhalation. That's going to make it pretty tough on exhalation for me to have something that's easy. If I take a lower breath, or what we call diaphragmatic breathing, I just functionally don't carry so much work. And so for me, rather than saying that there is a right or a wrong way to breathe, I just try and help my clients realize that there is a pattern or patterns to breathing that contribute to tension and tightness, and there are patterns of breathing that don't. And so what's their goal? Well, they want to feel easy with their voice. Well, then the choice tends to be a bit more obvious. And so what I will do with clients is actually guide them through. I will help them become aware of different breathing patterns, and then really, really deeply ask open questions. What feels good for you? Let's do that. And so when it comes to breathing, it's for me as simple as breathing with a client, becoming aware of it. We touch our own bodies to see where things are moving. I'm just kind of thinking about breathing way more functionally. When we get into like this falls under the voice hygiene thing. When we start telling people there's a right way to breathe, they start thinking they're doing something wrong, but it doesn't have to be that way.
Yeah, and I think a lot of that, I'm thinking inside my own brain right now.
Yeah.
For me, a lot of that is yoga related too, because
Yeah.
if you're someone who's a practitioner of yoga, you do a lot of breathing and you do a lot of placement of your hands on
Mm-hmm.
your chest or your diaphragm or both, and you're feeling your breath and you're sort of noticing the differences between breathing in through your nose and out through your mouth versus breathing in through your nose and out through your nose, which is, a resonance based thing if you're voicing.
Sure.
So I think that that's a good correlation for people who have practiced yoga too. They can maybe understand that piece of it a little bit better.
I think what's
Gosh,
helpful too, when it comes to diaphragmatic breathing and any voice pattern or voice behavior, is that the people coming to us do not have graduate degrees in voice, and they don't have graduate degrees in speech pathology. They have not thought about this as much as you have. And so taking our time with clients, I find to be really helpful. So when we're talking about something like diaphragmatic breathing, I have this deep understanding of how the diaphragm collaborates with the lungs and the lower airway and the upper airway. My client does not. And in
right.
fact, they have now been breathing for 30, 40, 50 years without ever considering how it happens. And so I take time, show a lot of pictures, show a lot of videos, and just help educate someone about how their own body works. And often through that process, they're like, oh, well, if this is how it works, maybe I can do it this way. And I'm like, great, I'm happy you came to that conclusion.
Works for me. Terry had a question about techniques for increasing a student's vocal volume.
Oh, interesting. I guess my first one, as a voice therapist, I'm like, is there anything impacting their ability to get louder at the level of the larynx? And if not, then loudness, intensity is effort and it is work. There's another, thing that I would hang in a therapy room if I had one all to myself. It would be that voicing can be work. Voicing can feel like effort. And so creating a louder voice, talking loudly for a long time can feel like work, and that's okay. They're muscles. And so sometimes when it comes to teaching someone how to use a louder voice, it means turning the voice on. It literally means being louder.
I'm sorry, there's so many questions. This is great. Because usually I get like one, maybe two. So this is helping me think of other things to ask you as well. Because this is along the same lines, and I'll switch to the other questions.
Yeah.
Someone said they had a student, Annette. I have a student who is a stutterer and his voice is very, very quiet. I noticed he had limited jaw movement when talking.
I do not see too many clients that have like co-occurring fluency and voice
Mm-hmm.
concerns. I guess from a mechanics of speech and voice, how we get loudness is more dynamic, right? So the vocal folds are more dynamic when they are creating a louder sound, and we are able to make louder sounds when we move our mouth more. So that would be the big correlation there. It falls under the similar like intensity based exercises for things like presbyophonia or Parkinson's.
Yeah, and someone did just ask a question about recommending particular voice, LSVT, skilled nursing setting, SLPs. I tend to not recommend a particular paid program because I'm not a paid spokesperson. I can only speak to things that I am certified in. But even then, I'm still hesitant because I don't want to make it appear as though I'm making a recommendation for something that maybe wouldn't be for you. So if it's Parkinson's related, I think you need to do your own research and maybe come up with your, look into it yourself and look at your practice and what you feel like would be beneficial if it's something like LSVT or speak out for a Parkinson's patient. That's just my spiel on that.
Sure. Yeah. I mean, I think about I'm sorry, what's the term that you used for that? Like what would we call that? It's like a
LSVT
or like a certification program or something. I don't
yeah,
actually think they're bad. I don't think they're negative. I
I
think
don't either.
sometimes as a clinician, it can feel limiting. So you
Hmm.
learn the thing and then you feel like one, it has to be applied the same way every time, or that patients who don't fall within the characteristics of the clients that do benefit from it will never benefit. It becomes a thing that we get locked into or people get locked out of. But I don't think that's how any of this needs to be used. And
Hmm.
so I've had certifications that I've held in the past, and I actually don't hold any right now just because I feel like the knowledge was helpful. And now I do my work as a clinician to apply that knowledge appropriately to the clients that I see.
Well, and when it relates to Parkinson's, I think that often people think that it's a voice disorder when in fact it's a dysarthria
Right.
that voice is a characteristic of. And so we have to be mindful of that and not call it a voice disorder when it's truly a dysarthria, where the voice problem is a manifest is a symptom of the dysarthria that we're seeing with hypokinetic dysarthria. Um, but there are a couple of other questions that are not related to Parkinson's, and so
Yeah, yeah, yeah.
someone asked about new treatments for spasmodic dysphonia.
Yeah,
Uh, didn't respond to typical hygiene treatment, so she's been getting Botox injections now.
sure. Um, yeah, I would say that still tends to be the standard if the goal is to reduce the perception of spasms in the voice quality and actual spasms at the level of the larynx. There's currently probably not a better tool, but things are changing very quickly, and there's some exciting research coming out about some treatment options for folks with spasmodic dysphonia. And so I think we will see those things as they come down the pipeline. Some of those are surgical, some of those are medical, pharmaceutical, and some of those are like therapeutic. So it's exciting. There's a lot happening. There's a lot of people that want to have better treatment options than Botox. But for right now, I'd say the most accessible of the treatment options is Botox. Yeah.
And then another question, any particular exercises or treatments for glottic insufficiency?
Yeah. Again, if there is a gap at the level of the glottis, thinking about like what's the cause of that gap, if it's a vocal fold atrophy or some form of tissue issue, maybe even something like scarring or sulcus, you have to consider, do I as a therapist actually have the ability to change the tissue? Often the answer is no, that's not what we do. What we do is functional adjustments to a system to help someone get a better functional outcome. And so therapy for glottic insufficiency can be extremely helpful even if you never zip up the glottis. And so I like to start off a lot of my therapy for folks that have glottic insufficiency with that. It completely depends on their concerns. Some folks with glottic insufficiency are very rough, some are weak, some are strained. And so we just go for what is their goal? Can we achieve that with behavioral therapy? If not, then we go back to the physician or the doctor to see if the glottic insufficiency can be addressed. And I would say that's where a lot of my practice patterns come from. I know some of my answers may seem shocking, like, oh, you only see a client 4 times, or you seem to have really strong boundaries over what you do or don't do. But I work side by side with a few doctors and 2 laryngologists. So if I am not getting success with a client, I bounce them right back to the doctor. And I'm like, this was probably just not a good therapy candidate. We don't have to spend 5 months blowing through a straw to figure that out. They would probably benefit from some form of intervention with you.
Yeah, no, I agree. And sometimes that's not, I found it to be a mixed bag for patients on what they want to hear, especially if they've been
Yeah.
bounced around a lot before they get to you. And I think that they sometimes have an opinion on like, well, you're supposed to be the expert. Why aren't you helping me? But
Yeah.
that's where we have the competency training so that we can say, from a physiological standpoint or a functional standpoint, we're not getting anywhere. We're not helping you. We don't need to waste your insurance benefits and your money. We need to get you to the correct person.
Sure.
And I think when you explain it in those terms, a lot of times patients are far more receiving of that than they are oppositional. because
Yeah.
they realize you truly are trying to help. You're not just trying to have them come in every week when you really are like just juggling,
Yeah.
right?
Yeah.
Yeah. Deirdre said she had a stroke in May. You can hear a change in her own vocal quality and appreciate what we're talking about. Thank you, Deirdre, for that. That's very sweet. Hope your recovery is going well. And then Joni also wanted to know maybe some voice related changes that happen in presbyophonia that she's not familiar with that term.
Yeah, so presbyophonia just kind of relates to the age-related changes kind of the entire system. So I tend to think about voice power source filters. So we have the lungs, the larynx, and then our articulators and resonance. And so there are changes kind of at every layer and level there that contribute to the perception of presbyophonia being kind of the acoustic correlate of, aging voice. But what we would see in presbyophonia on a laryngeal exam is maybe vocal cord atrophy or just thinning out of some of the vocal cord tissue, or maybe glottic insufficiency. They're all characteristics, not necessarily diagnoses. And then what we would probably measure is higher airflow during voicing. So like due to a glottic gap or due to weakness of the larynx. In some cases, you might actually kind of have lower airflow if someone is what I call a low phlonia patient. They just aren't really driving the system. So I think there are different categories even within one sound. That's what makes voice a little bit tricky sometimes, but it's a good question.
Mm-hmm. Yeah. And then we have another question from Lisa. For voice clients, I remember being told we cannot treat or evaluate without a doctor's order. Is this still true? I would just say yes. We can't really treat anything without a doctor's order. If yes, what kind of screener can we complete without an order? And Maurice, I'll let you answer that, but I will tell you that for me, I'm a big fan of the VHI, the Vocal Handicap Index, because it is a patient-reported outcome measure for the most part. So
Yeah.
what are some things that you kind of use as your go-to?
So again, my bias is that I work alongside physicians. So not only do I get a doctor's order, I get a laryngeal exam for every client that I treat.
Yeah.
Now I understand that is not possible. So I've even changed my recommendations. Do I think in a perfect world, every client would have access to stroboscopy who has a voice problem? Sure. Is that possible? No. And I think this is when we really turn on our clinician hats and our clinician brains. And I think that even trial therapy, just trying things with your clients, can be diagnostic. And so you're going to learn a lot about what's happening at the level of the larynx by trying something, right? If I have a patient do a voice glide and their voice cuts out before they get halfway through the glide, that's telling me something about the function. It may not be telling me what exactly is happening, but it's telling me something isn't working the way that it should, right? If someone can only do a max phonation time for 4 seconds, that's telling me something about the system that I know falls outside of normal limits. And so sometimes our job as a therapist is not just to make something good or better, it's to identify what's not working the way that it should be so that we can then advocate for what the patient needs. Sometimes that is us, sometimes that is not. And so I actually wear my diagnostic hat at all times. And I think that's really empowering to speech pathologists. I don't work for a doctor. I'm not a speech pathologist to follow a physician's orders. I am a provider myself, right? I have a degree that helps me decision make in the therapy room or in the intervention room with my clients. And so even though I, by insurance standards or any other standards, don't begin quote unquote treatment until I have orders from a doctor, I am still who I am with the training that I have, applying that, within my space.
Yeah. So I'm going to take the last 2 questions, and then after that, we'll have to sort of wrap it up. But one question that I want to make sure we cover before I take these other 2, do you have some accessible resources for clinicians that they can turn to kind of help increase their awareness and their knowledge?
I have created some things for speech therapy PD. So you can go there and have done some work there. I also, as you had mentioned in the beginning, have a continuing education project with a friend of mine called Voice Pro Ed, where we talk about the voice in this way. Sometimes there's more of a bend towards singers and performance voice, but if there's resources there that feel helpful to you. And then I'll give a shout out, to be honest, a resource that I've used a lot, Christy Knickerbocker from Tempo Voice has some really good stuff
Yeah, I agree.
that I find is both helpful for the clinician and the client to understand. And I have referenced her work a lot in my career when clinicians are like, where can I turn? Because I do agree that a lot of the stuff around voice can be very dense or incorrect. And so I find that Christy does a great job of presenting good information in a way that's understandable, in a way that's like, you can actually get the best that you squeezing the best out of it. Right.
Yeah.
And
Super
then if you
accessible.
need higher level stuff, you can go from there.
Yeah, I agree. I like her work as well. And I'm not a voice specialist by any stretch, but I still found her work to be very incredibly helpful and very accessible, not just to me, but students as well.
Yeah, it's
which
great
is always
for like early career or someone who's just getting into the area. I think it's presented really well.
Yeah. So Brittany asked about go-to treatments for someone with chronic cough. And I don't know if you also see patients with chronic cough after the patient has seen an ENT and is referred to SLP.
Yeah, chronic cough, it can be tough because there are so many things that can trigger chronic cough or kind of fall under the umbrella of ILO, inducible laryngeal obstruction. And that, can break down. So if you're looking for treatments, there was actually a paper, I think in Perspectives, that was like, the basics of behavioral cough intervention for the speech pathologist that I found really, really helpful. And then what I will do is spend a significant amount of time with my client talking about all of the potential irritants or stimuli that could be contributing to cough or to the perception of something going on in their throat, right? So it's either a globus, a tickle, a sensation, a fullness, a pain, a discomfort that causes a cough. And so we'll talk a lot about the cough. We will dissect it. People who have chronic cough love talking about their cough. So just talk about their cough with them. Affirm that their experience is real, because often these clients are told that they're making it up. There's nothing wrong with your throat. You're just making it up, or it's stress or anxiety or blah, blah, blah. It is real. It is a thing they are experiencing, and they're coming to you for help. And so then after we've kind of dug through it, I've affirmed that this thing is real, then we'll get to like behavioral strategies, and whether that be a hard swallow, the sniff, inhale, exhale, breathing through pursed lips. I'll even do things like laryngeal massage. I will do voice exercises in folks that have chronic cough if it feels like voice exercises help relieve that sensation. Again, it's like, what is the thing kind of contributing to the cough or the irritable larynx sensation? Targeting that will help kind of uncover a bunch of other things. And often folks with chronic cough will have multiple stimuli. They just don't realize it. They see it all as one cough. I am just coughing. But there are different characteristics to cough. There can be different triggers for the same cough. And that really does fall within our scope to help dig through that. And we have significantly more time than a physician to do that.
Yeah. And then the last question that I'll pose is, if it's just behavioral dysphonia with no apparent disorder, like obvious roughness, no ENT is needed. What about vocal fry? What about passive voice? No ENT needed.
Yeah, I guess if someone has vocal fry, again, vocal fry can completely be an appropriate choice, right? I can talk with you like this for the next 10 minutes, and it doesn't mean that I'm hurting my voice. I'm just using vocal fry. I don't know that that's the voice quality that I want, but again, I don't think we have data that demonstrates vocal fry like damages the tissue. I think it can contribute to patterns that result in tension or strain. But even then, right, if someone has vocal fry that they can't get out of, I would assume they probably have some sort of muscle tension pattern or behavior that's contributing to them feeling stuck. And then that kind of is a disorder. So we find ourselves back in the position of do the evaluation that you think the client needs, treat, right? Approach therapy diagnostically. And if they get benefit from your intervention and feel like their problems resolve, perfect. And if not, then refer.
Yeah, no, I agree. And, functional dysphagia and functional speech disorders have really come out of the woodwork of what we used to think they were early in my career. And so there's a lot of great research coming on about that. And it's sort of, I think it's all interrelated when it comes to that, because we're not just treating one thing or the other, or making the patient feel as if what they're experiencing isn't real, because you had a great point of, it's real for them. Yeah. It may not look like what we think it should look like, but that's not really our job to kind of say, no, this is not correct. It's you're feeling this thing and how can I help you?
Yeah,
That's the functional piece of what we do.
super helpful tool. I honestly think that alone has really shifted my practice in the last couple years, is just being able to, and we're all making fun of this like holding space for defying gravity lyrics thing, but really holding space for people to like say what's going on with them without, especially to a healthcare provider, especially to someone who's like involved in their insurance and who just says okay and doesn't try and negate it and doesn't try and explain it away. They just say okay, has been really helpful. And I think my clients have responded really well, especially folks with these sort of functional, odd patterns and behaviors that otherwise can't be explained by something measurable.
Yeah, I agree. Thank you, Maurice, so much for joining us. I just really think this was, for me, I knew this was going to be a learning experience for me. So I'm very grateful for you to share your knowledge and answer so many questions that were not kind of on the fly, right? We always have a plan as a podcast, not necessarily a script, but we have a plan. And I appreciate you being so willing to answer everybody's questions. So thank you for that. Anything else?
Yeah. Sorry.
No, I was going to say, anything you want to leave us with?
I was just going to say, I think at my core, I deeply believe that clinicians can feel really competent in their work, and they can confidently come into the spaces that they work in and do great work. And that sits at like the core of a lot of my beliefs as a clinician, because I feel like that changes my interaction with my clients. And so when we talk about what's the it factor, right? What helps clients get better? It's not about me. 100% it's not about me. And the way that I come into that space does make a difference. And so I want all clinicians to feel comfortable and confident when they're working with voice. That I desire for that. And I feel like some of these fundamental things, and we can learn from each other's clinical practice, are important. I think it's going to be the path forward.
Yeah, I agree. Thank you so much. I appreciate you being here, and I appreciate everybody for tuning in. Thanks again, Maurice. I look forward to seeing you soon.
Bye. Thank you. Thank you, everyone. Thanks for the great questions.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use Brainstorms20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.